G'day team, and welcome back to Overheard in the Emergency Room, the show where we take the real, sometimes raw, sometimes heartbreaking stories from the emergency department and turn them into practical lessons for your long-term health. I'm Dr. Kois, emergency physician, and today I need to start with a story that has stayed with me, one that genuinely made me angry, not at the patient, but at the system. It's the end of January 2025 and I'm working on a Monday afternoon shift. The department was stacked, waiting room full, cubicles full, ambulances still rolling in. In walks an 84-year-old woman. She came in on the bus because she doesn't drive and she doesn't have family in town. She sits in our waiting room for 4.5 hours. When I finally see her, her blood pressure is 220/104. She's got a headache. She's calm, a little embarrassed and apologetic about taking up my time. I told her there's nothing to be apologizing for. This situation is not her fault. So what's her story? For the past 20 years, she's seen the same primary care physician, same doctor, 20 years. She's been meticulous with her care, medications, follow-ups, all of it. Her blood pressure has been managed well. She's had no acute presentations for years. Then in the start of January 2025, a letter arrives. Her insurance company has decided they will no longer cover her long-standing physician. Her doctor hasn't retired, hasn't gone out of business. Her insurer simply decided they would no longer pay for her to see him. She calls around to try to establish with a new PCP her insurance will cover. The earliest appointment date she can get is June 2025, 5 months away. She's on a fixed income, around $60 a day. Paying out of pocket for her doctor's visit isn't an option for her. So she stops her antihypertensive medication because without a prescription, she can't get it filled. And then her blood pressure starts to climb until she gets a headache bad enough that she gets on a bus and sits in my waiting room for 4.5 hours. We do the right workup, full hypertensive emergency evaluation, CBC, CMP, troponin, CT of her head. Everything comes back unremarkable, no stroke, no end organ damage. We treat her blood pressure with her usual antihypertensive, get it down to the high 100s, and discharge her with a script and enough repeats to bridge her until June. I want you to sit with that for a moment. This woman did everything right. She had a doctor, she took her medicines, she engaged with healthcare system consistently for 20 years. She was not let down by laziness or ignorance, but by a system that prioritized its own structures over her access to care. The saying goes, an ounce of prevention is worth a pound of cure. But that logic only holds if you can actually access that ounce of prevention. When you can't, you end up needing the pound of cure. In an overcrowded emergency department on a Monday afternoon after a 4.5 hour wait. I keep coming back to this case because it is not unusual. Every week I see versions of this story, and today we are going to talk about why. This episode is about the US healthcare system, what makes it so expensive, so fragmented, and so inaccessible for so many people. And then, because I refuse to just be angry without offering something useful, we are going to walk through 3 serious proposals to fix it. So stick with me, because this one really matters. All right, this is where we go deep. Let's situate this episode within the framework that guides everything we do on this show. If you've been with us since the beginning, you know that every episode is anchored in what I call the 2-tier blueprint for long-term health. Tier 1 is the foundation. It consists of 5 pillars. Diet, what you put into your body consistently over decades. Exercise, how you stress your heart, muscles, your lungs, and how you do that on purpose. Sleep, whether your brain and body get the nightly reset they need. Meditation and stress management, how you can switch off your flight or fight response. And finally, having a primary care provider or GP. That's someone who is in your corner for screening for disease, prescribing when you need it, and advocating for you. Tier 2 is the upgrade pack. It's the supplements, the cold plunges, the saunas, the creatine. And even the most motivated patient needs access to screenings, vaccinations, and medications to stay healthy over the long run. Here's my thesis for this episode, and I want to be clear about it. The only true innovation in US healthcare that should matter to us right now is the innovation that makes healthcare accessible and affordable. Full stop. Everything else, the gene therapies, the AI diagnostics, the robotic surgery, those are extraordinary. But they're tier 2 innovations in a country that hasn't fixed tier 1. And until we do, People will keep riding buses to the emergency department with blood pressure crises that should have never happened. Let's get into it. The US healthcare system is the most expensive system of its kind on the planet, by a long way. And for that extraordinary price tag, Americans do not get commensurate outcomes. Let me give you the numbers, and then let's talk about why. The US spends more per person on healthcare than any other high-income nation, approximately $13,500 per capita per year. That's roughly twice what peer countries like Canada, Germany, France, and Australia spend. And yet, the US consistently ranks last or near last among wealthy nations on key outcome metrics: life expectancy, infant mortality, preventable deaths, and access to care. The Commonwealth Fund has been benchmarking this for decades. The pattern is remarkably consistent. Now, I want to add some nuance here, because nuance is what we do on this show. Because the US genuinely does some things brilliantly. If you're well insured and acutely ill, the depth of specialist expertise, the technology, the innovation, it's truly world class. Cancer survival rates for many diagnoses, cardiovascular intervention quality, pharmaceutical innovation. These are genuine strengths. The US is, in many ways, the best healthcare system in the world for people who have excellent insurance and need highly specialized care. But the real problem is access. The problem is cost. The problem is what happens to everyone else. Why is it so expensive? Let's talk about the big drivers. Driver number one, fragmentation and administration. The US healthcare system is not a system, it's a patchwork. You have different private insurance, hundreds of different plans, different networks, different formularies, different prior authorization requirements. You have Medicare, Medicaid, the Veterans Affairs System, the Indian Health System, CHIP, which are all funded differently, governed differently, operating differently, depending on which state you're in. Electronic health records frequently don't communicate with each other across different hospital systems or state lines. This means tests get duplicated, communication between providers breaks down, and continuity of care gets interrupted every time a patient crosses a system's boundary. Administrative costs in the US account for roughly 34% of total healthcare expenditure. For comparison, Canada, which has a single payer system, runs at around 12% administrative overhead. Nearly 4 million people are employed in healthcare administration in the US private sector in 2019 alone. One analysis found that if staffing patterns followed those of the Veterans Health Administration, that number would have been nearly 900,000 people lower. Think about that. More than a third of every healthcare dollar in the US is not going to a clinician, a diagnostic test, or a medication. It's going to paperwork, billing disputes, and the overhead of managing a fragmented multi-payer system. Driver number two, prices are simply higher. It is not primarily that Americans use more healthcare than people in other countries. In fact, Americans tend to visit doctors less frequently than people in many comparable nations. The difference is that everything costs more. An MRI in the US costs 5 to 10 times what it costs in Germany or Japan. Prescription drugs in the US are the most expensive in the world. The same medication can cost 3, 5, or even 10 times more in the US than in Canada or Europe. There is no unified negotiating entity to hold prices down. Prices are largely set by what the market will bear. And when someone is sick, scared, and needs treatment, the market will bear a great deal. Driver number three, fee-for-service incentives. The dominant payment model in the US healthcare system is fee-for-service. Providers get paid for each test, procedure, and visit. Volume drives revenue. This creates a structural incentive toward doing more instead of doing better. And this is not an indictment of individual clinicians. Most of the doctors and nurses I know are extraordinarily principled people, but a system that rewards volume does not automatically reward prevention, coordination, or the kind of 45-minute conversation with a patient that uncovers the real drivers of their health. A primary care physician spending an hour navigating a patient's hypertension management and helping them make lifestyle changes that could prevent a stroke gets paid the same or less than a quick specialist procedure, and it's that incentive structure that shapes behavior at scale. Driver number four, the uninsured and the underinsured. The downstream cost of this is one that I see every single shift. When people can't afford or access preventive care, they delay. And delayed care in chronic disease is extraordinarily expensive. A diabetic patient who can't afford insulin doesn't just have elevated blood sugar. They eventually come to me in diabetic ketoacidosis. A patient with uncontrolled hypertension doesn't just have a high number on the machine. They eventually come to me with a stroke or a hypertensive emergency. just like our 84-year-old patient from earlier in this episode. Emergency care is the most expensive care there is. The ED is not a cost-effective way to manage chronic disease. But for people without a functioning front door to the healthcare system, it becomes the default. The research confirms this. High emergency department users are less likely to have outpatient follow-up and more likely to miss out on screenings and preventive care. We are spending enormous amounts of money on the consequences of not preventing disease, while chronically underinvesting in the systems that prevent it. Driver number 5, monopolisation, the opposite of free market competition, which the US touts. We'll come back to this in the myth-busting segment later on, but I want to flag it here. The healthcare industry in the US has undergone massive consolidation. Hospital systems merge, insurer pharmacy benefit manager integration concentrates market power. This is not a free market. This is a market dominated by large entities with substantial pricing power and limited competitive accountability. Now, let's talk about 3 important proposals that have been put out there to try to fix this. I'm not just going to sit here and catalog the problems, because problems without solutions is just despair, and I'm not in the business of despair. There are some serious proposals on the table to restructure the US healthcare system, and I'm going to walk you through all 3 of them. Each represent a genuinely different philosophy about how to get a better outcome. Option number 1, Medicare for all. Medicare for all is a proposal to replace the current fragmented multi-payer system with a single government-administered health insurance program covering all Americans. The most prominent current version is H.R. 3069, introduced to the 119th Congress by Representative Pramila Jayapal. Under this model, every American is automatically enrolled from birth. There are no premiums, no deductibles, no co-pays at the point of care. All medically necessary care, that's hospital, physician, dental, vision, and mental health, as well as long-term care, is covered. The private insurance industry, as it currently exists for primary health coverage, is effectively eliminated. There is a single negotiating entity, the government, which sets prices for drugs, devices, and provider fees. The evidence behind this model is substantial. A landmark analysis published in the Lancet by Galvani and colleagues modeled the impact of a Medicare for all system and found that it would generate approximately 13% savings in national healthcare expenditure, which is equivalent to more than $450 billion every year. They estimated that universal coverage would save more than 68,000 lives per year and 1.73 million life years every year compared to the current system. Administrative savings are the major driver. One payer, one billing system, and the overhead collapses. The trade-offs are real and worth naming. There would be significant federal expenditure and tax increases during the transition period, though proponents argue that the net cost to Americans would decrease once employer and individual premiums are eliminated. Approximately 160 million Americans currently get their insurance through the employer, so this transition is not trivial. Fee levels for providers would likely be set closer to the current Medicare rates, which are lower than private insurance, though expanded utilization may offset this for provider revenues. More on this in the myth-busting section. The political feasibility has been the persistent barrier. Despite strong public support and physician endorsement, legislative progress has been extremely limited. Medicare for All is the most ambitious and in many ways the most evidence-aligned proposal on the table. If I were to design a system from scratch, I would be in this neighborhood and in this camp. Option 2, the Great Healthcare Plan. In January 2026, the Trump White House released a one-page framework titled The Great Healthcare Plan. The Kaiser Family Foundation has published a useful independent analysis of what this framework contains and, critically, what questions it leaves open. The broad philosophy of this approach, consistent with Republican healthcare policy, is a market-oriented one. The goal would be to deregulate, to increase competition and drive prices down, expand consumer choice, more plan types at different price points, promote price transparency so patients can make informed decisions, expand health savings accounts as a vehicle for tax-advantaged healthcare spending, give states more flexibility in Medicaid administration through block grants. Although it's not my favorite, there are elements of this approach that have genuine merit. Price transparency is a real need. The administrative burden of regulatory complexity is real. Consumer empowerment is a legitimate goal. But the KFF analysis flags significant open questions that this framework does not resolve, particularly around pre-existing condition protections and what happens to coverage for people who are already sick. And this points to the fundamental structural challenge with market-based approaches in healthcare. Healthcare is not a standard market. When you have appendicitis, you don't comparison shop. When you're having a stroke, you don't negotiate. When you're elderly, diabetic, and uninsured, your bargaining power is minimal. Markets work best when consumers can walk away. In acute medical care, you cannot walk away. And critically, we've tried this approach. The US has had the most market-oriented, least regulated healthcare system among wealthy nations for decades. And what's the result? Well, it's the most expensive system with outcomes that rank last among peers. The experiment has been run. The results are in, and it's not working. Option 3, the Embrace Plan. The Embrace Plan is basically about expanding medical and behavioral resources with access to care for everyone. It was proposed in a paper published in the Annals of Internal Medicine by Lancaster and colleagues on behalf of healthcare professionals for healthcare reform. And I want to be upfront. This is the framework that I find most compelling, and I'll explain why. The Embrace Plan proposes a tiered universal coverage model. Tier 1 of Embrace would include universal, publicly funded, lifetime basic coverage for the entire population. This covers all care considered life-saving, life-sustaining, or preventive, based on the best available evidence. Tier 2 of Embrace is optional private insurance coverage for therapies that address quality of life and functional impairment, beyond the publicly funded essential core, and private companies can't also cover what's included in Tier 1. Tier 3 are the luxury cosmetic items that are generally not covered, similar to the current system. This system would be overseen by a quasi-governmental, largely independent organization called the National Medical Board, which would be modeled on the Federal Reserve. It would be funded by Congress through interval appropriations, but structured to remain insulated from short-term political pressures. It would be composed of physicians and key healthcare stakeholders. Why does this matter? Because one of the deepest structural problems with the current system is that it is politically captured. Insurance companies, pharmaceutical companies, hospital systems, and device manufacturers all have enormous lobbying power that shapes legislative outcomes. An independent board, like the Federal Reserve, creates a governance structure that can make evidence-based coverage and reimbursement decisions without being constantly overturned by the next election cycle. Embrace achieves the same fundamental goal as Medicare for All, that is, universal coverage through a single-payer system that creates a large enough risk pool for efficiency and removes the fragmentation that drives administrative costs through the roof. But it does so by building on existing structures rather than dismantling them overnight, which is not a compromise of principle, but a recognition of political and structural reality. The history of Medicare for All is a history of legislation that reaches committee and goes no further. Embrace provides a pathway that has a realistic chance of being enacted. There is also an important piece of this that I want to highlight. Embrace explicitly incorporates the full spectrum of medical and behavioral resources. That is mental health, substance use disorder, dental, and vision. The arbitrary separation of these from physical healthcare in the current system is clinically incoherent and deeply harmful. Any serious reform must address it. All right, we talk a lot on this show about how misinformation spreads on social media when it comes to health topics. The dynamics play out when we talk about healthcare reform in the exact same way. Before I walk through some specific myths, I want to name the misinformation tactics that you come up most often in this space, so that you can recognize them when you see them. Let's talk about our pre-bunking framework and how we'll use it for this episode. Watch out for these 5 tactics. Number 1, oversimplification of complex topics, reducing a multi-system, multi-decade problem to a single villain or a single fix. Appeal to nature. Competition is natural, therefore it'll work, without examining whether the preconditions for competition actually exist in the market. Over-reliance on mechanism over outcome data, arguing how something should work in theory rather than showing what happens in a practice when you study it. the supplement-centric business model. Someone proposing a solution happens to profit from that solution. Follow the money before you follow the argument. And the anti-establishment framing. The medical establishment is lying to you to keep you sick. This is a rhetorical device, not an argument. It is designed to make you distrust evidence rather than engage with it. Now, let's go through 3 specific myths. Myth number 1, universal healthcare would collapse physician salaries. So the claim here is that if we move to a government-run or single-payer system, physician reimbursement will drop dramatically. Doctors will stop practicing, the quality of care will decline. So why do people believe this? It's not an accident. The lobbying group Partnership for America's Healthcare Future spent over $100 million annually opposing both a public option and Medicare for all. There's been deliberate, well-funded, fear-mongering targeting physicians, a constituency that has legitimate concerns given the burden of student debt, the length of medical training, and the fact that current Medicare reimbursement rates are lower than private insurance rates. And it seems that physicians are split roughly 50-50 on this issue, which tells you that the campaign has been really effective. But what does the evidence say? The Nonpartisan Congressional Budget Office analyzed payments to physicians expected in 2030 under current policies and under 5 different options for Medicare for all. It found that weighted average of public and private payments to physicians would increase to 116% of the 2019 weighted average under current policy versus between 108 and 117 under the various Medicare for all options that were analysed. But here's the critical insight. Because Medicare for all would increase society-wide utilisation of care, bringing in tens of millions of people currently avoiding care due to cost, total provider revenues are projected to actually increase even if fee-per-service fee levels were to decline. More patients, better access, higher volume. So what's your takeaway? If you're a physician worried about what Medicare for all would do to your income, the CBO, which is not funded by healthcare reform advocates, projects that total physician revenues would likely increase. The per fee level argument misses the utilization picture entirely. Myth number 2. The government can't be trusted to run healthcare. The claim here is that government programs are inherently inefficient. They say that bureaucracy will destroy the quality of care. Just take a look at the DMV. You want the people who run the DMV to run your healthcare? So why do people believe this? This is over-reliance on mechanism over outcome data tactics. There is a general cultural narrative in the US about governmental inefficiency. But this argument substitutes a stereotype for actual evidence. And we don't need to speculate about how government-run healthcare would actually perform. We already have a case study. So what's the evidence? The Veterans Health Administration, or the VA, is a government-run, fully integrated healthcare system. And it's not perfect, and it has well-documented issues. But the comparative quality data is striking. A living systematic review by Shekeli and colleagues examined 69 studies published since 2015, comparing VA care to non-VA care across surgical and non-surgical settings. And what did they find? Well, they found that most available studies showed that the quality and safety of VA care is as good as or better than care in the community at non-VA hospitals. On administrative efficiency, the contrast is even starker. Analysis published by Physicians for a National Health Program found that nearly 4 million people were employed in healthcare administration in the US private sector in 2019. If staffing patterns followed those of the Veterans Health Administration, the current government-run system, that number would have been nearly 900,000 lower. That's less overhead, lower administrative burden, and comparable or better clinical quality. So what's your takeaway on this myth? We already have a government-run healthcare system in the US, the VA. Most published comparative studies show that it delivers the same or better quality care compared to community care. So the argument that government cannot run healthcare is just not supported by the evidence we already have in hand. Myth number 3, free the market and competition will bring down prices. So the claim here is that the problem is that there's too much regulation, and if we deregulate, allow more competition and let the market work, prices will come down, just like they do in technology, in cars, and every other industry. Why do people believe this? This is the supplement-centric business model tactic applied in healthcare policy. The people most loudly arguing for market-based deregulation tend to benefit financially from the current structure, and the appeal is intuitive. Competition works in other markets, so the argument has surface plausibility. But let's look at the evidence. What market competition has actually produced in US healthcare? Specifically, let's look at pharmacy benefit managers, or PBMs. PBMs are the middlemen who administer prescription drug benefits on behalf of insurers. They are supposed to negotiate lower drug prices. The argument was that competition between PBMs would drive down costs. A 2025 AMA report on competition in PBM markets found that just 4 PBMs, CVS Caremark, Express Scripts, Optum Rx, and Prime Therapeutics, control approximately 2/3 of the entire market. That's not a competitive market. That's an oligopoly with vertical integration. PBMs owned by the same companies that own the insurers, that own the pharmacies. And the result? Double dipping on administrative costs. Markups that flow through multiple entities before reaching the patient. Opaque pricing that neither physicians nor patients can interrogate. What's your takeaway? We have been running the free market healthcare experiment for decades. And the result is not lower prices or better access. The result is large monopolies, vertical integration, and costs that are double those of any comparable nation. The experiment has been run. Market competition without structural constraints does not produce affordable, universal healthcare. Let's bring this back to the blueprint, because this episode isn't just political analysis or economic analysis. It's about your health and the health of the people around you. Pillar 5 of Tier 1 is having a primary care provider. And the evidence for why this matters is not subtle. Patients who are frequent emergency department users, that is, people who come to the ED repeatedly, are more likely to have fewer outpatient visits and are more likely to miss out on preventive screenings. This is not coincidence, it's a systems failure. When the front door to healthcare, the primary care provider, is inaccessible, the back door, the emergency department, becomes the default. And the back door is not set up for prevention. It is set up for crisis. A robust primary healthcare network is how patients receive vaccinations. It's how cancer screenings happens. It's how blood pressure gets detected before it reaches 222/104. It's how diabetes gets caught at pre-diabetes, not after a hyperosmolar crisis. It's how a physician sits down with a patient and helps them translate evidence about diet, exercise, sleep, and stress management into actual behavior change. No pill, no procedure, no amount of expensive acute care undoes what accessible, consistent, longitudinal primary care prevents. The 2-tier blueprint works: diet, exercise, sleep, stress management, and primary care. But Tier 1, Pillar 5 is the pillar the US healthcare system is actively undermining, and that has got to change. Let me come back to that 84-year-old woman from the start of the episode. Here's what happened when she landed in my emergency department on that Monday after. My department ran the full hypertensive emergency workup. She occupied a cubicle in a fully stacked apartment for hours. Our nursing staff, techs, residents, they had to spend time on a presentation that was entirely preventable. She sat alone on a hard chair in a fluorescent lit waiting room for 4.5 hours, having ridden a bus to get there because she had no other options. The hospital will generate a significant bill for this encounter. None of that had to happen. She had a doctor for 20 years who had been keeping her well. She was doing everything right. She was let down by an insurance structure that is designed around profit, not around patients. And this is what motivates me to learn about this, to talk about it publicly, and to advocate for change. Not from an ideological position. I'm an emergency physician, not a politician, from a clinical one. Because when I think about healthcare reform, I don't think about policy abstractions. I think about her and the version of her who is 60 and 45 and 30, and the version who doesn't make it to the ED in time because the barrier to care was just high enough that they waited too long. The saying is right, an ounce of prevention is worth a pound of cure, but only if you can actually get the ounce. We have the evidence, we have the proposals that could work, but what we need is the will to implement them. And that requires an informed public that understands what the problems are and refuses to accept the current system is the best we can do. So what should you do this week? Number 1, if you have a primary care provider, call them. Book your annual appointment if you haven't had one. Get your blood pressure checked, get your basic screening labs. Screenings and vaccinations are the preventive infrastructure that the healthcare system should be delivering consistently for everyone. Number 2, if you don't have a primary care provider, book one today. Even if the wait is months out, the appointment in June still matters. Don't wait for the bus ride to the emergency department. Number 3, learn to navigate the system on your behalf. If you receive a medical bill, call your insurer and the hospital to understand the itemized charges. Challenge them. Insurance companies will try to get away with everything they can. You have the right to question it. Before elective procedures, ask for the cost estimate up front. Shop around where it's appropriate. Federal law now requires hospitals to publish their prices, so use that. Number 4, get politically informed. Research candidates who have clear, evidence-based positions on healthcare reform. This isn't about party affiliation. It's about whether people you elect understand the system where a 84-year-old woman has to ride the bus to an emergency department because their insurer dropped their doctor, and acknowledges that that is simply not acceptable. And that's it for this episode. Thank you for staying with me through a heavier one today. I know that we don't always go this deep into policy, but I genuinely believe that this is the foundation that makes everything else we talk about on this show possible. Coming up next week, your blood testing toolkit and a guide to screening for disease prevention. This one will be a bit more practical and a lot more actionable for anyone who wants to know what to actually ask their doctor to check and why. If this episode helped you understand something important, please like, subscribe, and share it with someone who needs to hear it. It genuinely matters for getting evidence and nuance into a space that has too much noise. If you don't mind as well, drop a comment. I want to know what you think about this show. I want to know your experience with the healthcare system. I want to hear from the physicians in the audience who have opinions about these proposals. You can find more resources, the episode companion blog post, and everything else we do at drkois.com. Remember, we're chasing fewer bad days and more good decades. I'll see you next time.